This is the third installment for vaginal bleeding. We're still talking about the reproductive age females, only now she's not going to be pregnant, and we're going to start talking about anatomy and dysfunctional uterine bleeding. We're not going to talk about the postmenopausal bleeder because that is almost exclusively endometrial carcinoma and vaginal atrophy, which is talked about in the endometrial carcinoma lecture. So let's start off talking about the reproductive age female who has bleeding due to her anatomy. She's going to have some sort of anatomical defect, of which there are really three major forms. Fibroids, which we're going to spend the most time on, adenomyosis, and polyps. To give you an idea of what these are about, the normal uterus sort of looks like this. With fibroids, there's going to be an asymmetric and nodular appearance to the uterus. In adenomyosis, the uterus is normal, but the myometrium is filled in symmetrically, replacing the lumen with a large, thickened uterus. So the normal lumen is much smaller, whereas in fibroids, the normal lumen is simply taken up by a bunch of fibroids. And polyps, a normal uterus simply has a little dangly. All of these can present with bleeding. All of these can present with infertility. The one we're going to talk the most about is fibroids. But before we do, I just wanted to compare fibroids and adenomyosis. Fibroids, asymmetric and nodular growths of the myometrium. Adenomyosis is essentially endometriosis of the myometrium, symmetric and smooth uterus that has essentially been replaced by almost all muscle. So let's talk about fibroids since they are so common and you're likely to get many questions about them. First, fibroids are benign. That is, they are not cancer, and they are growths of estrogen responsive. This is critical to their treatment. They are estrogen responsive pieces of muscle. They are from the myometrium. Myo meaning muscle, myometrium layer. They are not cancer and they are estrogen responsive. They can present in many numbers of ways. They may simply be asymptomatic nodularity, masses found when you do your physical exam. They may bleed and cause anemia. Why we're talking about them now. They may cause infertility because if the uterus looked like the one I drew, there's no place for the uterus to implant. They may simply be painful, and if they get really big or bad enough, they can actually cause visceral obstruction. Visceral obstruction of the ureters, bladder, urethra, small bowel, large bowel, they can go anywhere. The diagnosis is going to be made, because this is OBGYN, first by an ultrasound. But the best test is actually the MRI, because the MRI can differentiate the leiomyoma, the benign estrogen-responsive layer of the myometrium, from leiomyosarcoma, the cancer that comes from the myometrium. So you're going to see the nodular asymmetric uterus on ultrasound. You probably suspected it based on physical diagnosis alone. You confirm it with an MRI. You do not have to biopsy fibroids. The treatment is going to be dependent on what mom wants. If your patient wants to have more kids, you are simply going to perform a myomectomy. You're going to get rid of the fibroid that's causing all the problems. If she does not want kids, a much easier procedure, and it's more benign for mom, is simply a total abdominal hysterectomy. It's easier to take the whole uterus out than try to scoop out the individual fibroid, and this way you'll ensure that no additional fibroids can grow. And as a caveat point, if it is too big for surgery, because it is estrogen responsive, you can use leuprolide continuously shut off the axis, have the tumor shrink, and then proceed with either of your surgeries. So that is anatomy: fibroids, adenomyosis, and polyps, simply diagnosed on physical exam, ultrasound, or hysteroscopy. Let's now talk about the diagnosis of exclusion, the last one on our list: dysfunctional uterine bleeding. And I will say first that the way you diagnose it is by excluding everything else. That means you've gotten a CBC, you've gotten the TSH, because thyroid disease on its own, either hyper or hypo, can mess up bleeding cycles. Prolactin, you've probably got an ultrasound, you may have even got an MRI. And once your workup is totally normal, and you have not found the cause of her vaginal bleeding, but it is abnormal, it's considered dysfunctional uterine bleeding. The pathology is something like this. It's essentially an ovulation. Because in the beginning of a cycle, estrogen is primarily made, which causes proliferation of the endometrium. At day 14, ovulation occurs, the egg pops out, and is primarily progesterone driven. This decreases proliferation and increases the secretory uterus. Which means that if there was no ovulation, there'd be no switch from estrogen to progesterone. It'd be primarily estrogen, primarily proliferation. And eventually, the endothelial lining gets so large that it simply outgrows its vascular supply and sloughs off. And rather doing it at scheduled periods every 28 days, instead it just happens whenever it happens to get too big. So it'll happen in between normal cycles because there is no cycle occurring, because there is no ovulation. This process is normal as the system gets going in the first couple of years and as the system begins to end. So near menarche and near menopause, dysfunctional uterine bleeding is normal. It's why that women, as they approach menopause, will have spotting, or will go a couple of cycles that they miss and then bleed again, simply because dysfunctional uterine bleeding is normal near menarche and near menopause. The cause of dysfunctional uterine bleeding in the normal reproductive age range isn't really known. And people will say it's stress or anxiety or weight loss, but that's not really the cause. And so you'll have options on your test to reduce stress. And that's not really going to work. You'll also have an option to gain weight. And unless she's anorexic or has been doing significant marathon running, that's probably not going to be it either. Both of these usually cause amenorrhea, not dysfunctional uterine bleeding. But if you do spot some major stressors or some significant changes in her weight or exercise, counsel her to go back towards normal. What you can do is put her on OCPs. Essentially reset the axis so that she begins having normal cycles and is not fully controlled by estrogen. And this next one actually makes people recoil because she's bleeding. She could have a bleeding disorder. We haven't talked about it yet, but yes, people who bleed from their vagina might have a platelet dysfunction disorder, and you need to check out the platelet disorder diseases in medicine. But if she actually has dysfunctional uterine bleeding, you give her NSAIDs. People recoil from this because she's already bleeding and you're going to give her an antiplatelet. It turns out the effects on prostaglandins are more than the effects on platelets, and it actually slows down her bleeding. So don't feel bad about giving her oral contraceptives and NSAIDs. And we've talked about this already in the opening lecture. If she has very significant heavy bleeding right there in front of you, give her IV estrogen. If she has life-threatening vaginal bleeding right now in front of you and it's not responsive to IV estrogen, go in to ligate some arteries or take out the uterus. You have to save her life. If she has really significant bleeding that's causing anemia and you haven't found the answer and she's got dysfunctional uterine bleeding, you can use oral contraceptives. Because it's not an emergency, if she continues to have bleeding that makes her anemic and you can't figure it out and you can't control it, that's the time that you move towards ablation or total abdominal hysterectomy, especially if she doesn't want any kids. And the thing that I want to close with is that dysfunctional uterine bleeding is often diagnosed because people miss polycystic ovarian syndrome. And PCOS, as you're going to see throughout these video series, this is the time we're going to spend the most time on it so that you know all the details of the disease. Polycystic ovarian syndrome is caused by anovulation. And in its place are thousands of atretic follicles. They produce testosterone. And anovulation produces a lot of estrogen, but because there's no ovulation, there's no progesterone. The patient is going to be a product of all of this testosterone and all this estrogen. She's going to be hirsute, which basically means fat and hairy. She's going to have significant hair development, and she's going to be gaining weight. She may have a deep voice. Although this is getting more into virilization. And she'll present with anemia because she's having essentially dysfunctional uterine bleeding. Because she's anovulatory, she has only estrogen, which builds the endothelium, which essentially outgrows its own blood supply and sloughs off. But she may also simply present with infertility because she's anovulatory. And this is the way patients get endometrial cancer in the reproductive age group because of all of that estrogen exposure. So PCOS is about estrogen exposure causing infertility, endometrial carcinoma, and anemia from sloughing off of the endometrium, and testosterone causing her to get fat and hairy. This is actually an endocrine diagnosis. Many people are going to get the ultrasound, and the ultrasound is going to show you the thousands of follicles. You do not need the thousands of follicles on an ultrasound, and it will be an option. And you should not pick it because you do not need it. It is an endocrine diagnosis. What you're looking at is an elevated testosterone, but normal DHEAS. This is the adrenal form of androgen to show that it's not an adrenal problem, it's just an ovarian problem. And you're going to get an LH to FSH ratio greater than 3. And you may see diabetes mellitus diagnosed by a 2-hour glucose tolerance test. If you have the endocrine diagnosis, you do not need the ultrasound. The ultrasound is just gravy. To treat this patient, you're going to reset her axis with OCPs. You're going to treat her with metformin to control the diabetes. And if she wants to get pregnant, she'll need to induce ovulation by using clomiphene. So this concludes the 3 segments on vaginal bleeding. We've covered initially the differential diagnosis based on age, then covered precocious puberty in the first video. In the second video, we covered what happens in early pregnancy, vaginal bleeding with a positive UPT. Determine if it's an abortion, an intrauterine pregnancy, or an ectopic. In this final segment, we've covered more reproductive age bleeding caused by anatomy, fibroids, adenomyosis, and polyps. And then finally, the diagnosis of exclusion, dysfunctional uterine bleeding, which is probably based on anovulatory cycles, the most common cause of which is PCOS. If you've diagnosed dysfunctional uterine bleeding, make sure you've ruled out PCOS because that is a disease you can easily treat and change your life. This concludes vaginal bleeding. We make these videos for free, and we need your help. Please donate, because without your donations, we can't make any more videos. Please donate.